Welcome back to my lecture. Today, my lecture is on vesicovaginal fistula, that is resulting from mismanagement of the labor or the complication of the surgery. And this is very important topic for the exams. In any exam from undergraduate to the postgraduate exam, and this is very important for the public awareness program too. The women that are living in the developing countries that develop the vesicovaginal fistula, she must know how it develops. So हो सकता है कि मैं लेमन लैंग्वेज ना बोलूँ इसमें एंड मेडिकल लैंग्वेज ज़्यादा यूज़ हो मेरी बिकॉज दिस इज़ फॉर मोस्टली फॉर द डॉक्टर्स. So vesicovaginal fistula, let's see what's this. The fistula is defined as an abnormal communication between two or more epithelial surfaces. Two or more epithelial surfaces. The urinary tract fistula connects the genital tract, the vagina, uterus or perineum and the urinary tract, the bladder, ureters or urethra. See here, this is the genital tract, this is the uterus, this is the cervix and this is the vagina. This is the urinary tract, this is the bladder, this is the urethra. So connection between two epithelial cells, the one epithelial cells of urinary tract and the one epithelial cells of the genital tract, there is communication. This is called the fistula. So incidence of the fistula, its estimated prevalence in the developing world is 1 to 2 per 1,000 deliveries. Higher rates are found in Nigeria, Ethiopia, Sudan and Chad. The rate of urogenital fistula following hysterectomy has been estimated at 1 per 1,300 operations. So these are the types of genitourinary fistula. If the communication between the vagina and the bladder, that's called the vesicovaginal fistula. See here, this is the communication between the bladder and the vagina. This is the vesicovaginal fistula. Vesicourethral fistula. This is the uretrovesicovaginal fistula. यूरिथ्रा का भी है, वजाइना का भी है, दोनों का फिस्टुला बन चुका है टू द वजाइना. द थर्ड वन इज द यूरिथ्रोवजाइना, ओनली यूरिथ्रा का वजाइना के साथ है. द फिफ्थ वन इज द वजाइको सर्वाइकल, दैट इज द वजाइको सर्वाइकल. दिस इज द सर्विक्स. Uretrovaginal, this is the uretrovaginal. Ureteric ends, they are communicate with the vagina. This is the vagina, uretrovagina. This is the vagina. So vesico-uterine, this is the vesico-uterine. ये ब्लेडर है, ये यूट्राइन है, ये यूरेटर है. This is the ureter, uretrovaginal. So these are the types in the pictorial diagrams. You will easily understand. Vesicovaginal fistula is the most common type of genitourinary tract fistula. If the examiner is asking from you what is the common type, you say that this is a vesicovaginal. How we define it? It's a communication between the bladder, the vagina and the urine escape into the vagina causing true incontinence. So this is the form of true incontinence. यहाँ पे कंट्रोल नहीं होता है और हर वक्त यूरिन बहता रहता है. So let's see what are the causes, why this occur, what are the reasons. These are obstetrical and the gynecological. So causes divided into obstetrical and the gynecological. In the obstetrical, in the developing countries, the most common cause is obstetrical, that is 80 to 90%. 5 to 15% in the developed countries. So हमारे जैसे countries जहाँ पे पाकिस्तान है, बांग्ला है, इंडिया है, इथोपिया है, सूडान है, अफ्रीका का countries है, वहाँ पे 80 to 90% obstetrical cause है. In the developed countries, it's 5 to 15%. The fistula may be due to ischemia or following trauma. Ischemia results from prolonged compression effect on the bladder base between the head and the symphysis pubis. In the obstetric labor, ischemia, necrosis, so it takes few days, 3 to 5 days following delivery to produce such type of the fistula. अगर किसी भी औरत को आफ्टर डिलीवरी 3 से 4-5 दिन में डिस्चार्ज हो, वाटरी वजाइनल डिस्चार्ज could be due to the fistula, the offset fistula resulting from obstetric labor. Traumatic, this may be caused by instrumental vaginal delivery, especially the Killian forceps. Injury may also be by bony spicule of the fetal skull in craniotomy operations. Hysterectomy for ruptured uterus or caesarean section, especially the repeat caesarean section or for caesarean hysterectomy. The injury may be direct or ischemic, following a part of the bladder wall being caught in the suture. So, direct injury or ischemic when the bladder wall caught in the sutures. This type of direct traumatic fistula usually follows soon after delivery. So, soon after delivery, यूरिन निकलना शुरू हो जाए, so indicate the trauma. 3 से 5 दिन के बाद शुरू हो जाए, indicate the ischemia. Gynecological causes, though they are rare in the developing countries, it's the most common type met in the developed ones and account for more than 80% of the fistulas. Operative injuries which are responsible for this gynecological, in the gynecological causes, the operative injuries which are responsible for the fistula including the anterior colporrhea, abdominal hysterectomy for benign or malignant lesion or removal of the coordinate 6. Traumatic, that is fall on pointed object by a stick used for criminal abortions, following fracture of pelvic bones or due to retained and forgotten pessaries. Malignancy, advanced carcinoma of the cervix, vagina or bladder may produce fistula by direct spread. Radiational fistula may be resulting from the ischemic necrosis, and it usually takes longer time, 1 to 2 years to produce a fistula. Infections, chronic granulomatous lesions such as the vaginal tuberculosis, lymphogranuloma venereum, schistosomiasis, or actinomyces may produce fistula. So these are the causes of the fistula. This is the list of the fistula, the etiology of the urogenital fistula. What are the types? How we classify the fistula? Fistula may be classified as simple or complicated, or fistula may be classified depend on the site of the fistula, or depend on the etiology, or depend on the anatomical structure involved. So according to the complexity, the simple or complex fistula or complicated fistula, that is on the following criteria. When the fistula is up to 3 cm in size, their location is in high vaginal, supratrigonal, pelvic malignancy is absent, no prior radiation, and vaginal length is normal, this is the simple fistula and easily treated. When the fistula is more than 3 cm, it's mid-vaginal, its involvement of the trigonal areas, pelvic malignancies or radiational history is present, and vaginal length is shortened, that may lead to the difficult surgeries. So this is the complicated fistula. The repair will be difficult, and the prognosis is lesser than this simple fistula. Coming to the site of the fistula, it's a juxta cervical close to the cervix. The communication is between supratrigonal region of the bladder and the vagina. That is also called the vault fistula. Midvaginal fistula is the base, the trigone of the bladder involving the vagina. Juxta-urethral, the communication is between neck of the bladder and the vagina. It may involve the upper urethra as well. Subsymphyseal, circumferential loss of tissue in the region of bladder, neck and the urethra. The fistula margin is fixed to the bone. So this is the difficult fistula. Depending on the etiology, it may be congenital or it may be acquired. Congenital is due to abnormal fusion of the ureteric bud and the mullerian with the urogenital sinus, or due to abnormal development of urorectal septum. Acquired fistula, that depend on the anatomical structures. whether bladder is involved, whether urethra is involved, whether ureter is involved, whether uterus is involved, whether cervix is involved, or whether ureter is involved. So that is depend on the anatomical structures. How the patient present to you, how you suspect that she is in a fistula. So continuous woman who is in a continuous escape of urine per vagina is the classic symptom. The patient is got no urge to pass the urine. सारा urine बह जाता है. If the fistula is small, the escape of the urine occurs in certain positions and the patient can also pass urine normally. Small and oblique fistula, हर वक्त यूरिन नहीं बहेगा, तो उसमें किसी खास पोजिशंस में यूरिन एस्केप होता है and patient can pass urine normally. The such history has got a positive correlation with the related events. Leakage of the urine following direct surgical injury result from the first operative day. The first operative day or the post-operative day. The obstetric fistula, the symptoms usually take in 7 to 14 days to appear. Urethral fistula that are situated higher up often present with the features of stress incontinence. Vesicovaginal fistula may present from days to weeks after laparoscopic surgery. Radiational fistula present 1 to 2 years later. The woman with vesicocervical or vesicouterine fistula may hold urine at the level of the uterine isthmus and may remain continent, but they complain of cyclical hematuria at the time of menstruation. Sometimes women may complain of intermittent leakage of the urine. So, if the woman who is in cyclical hematuria during the menses, you suspect she might is the vesicouterine fistula. Information of prior surgeries, the pelvic malignancies, radiation therapy, prior failed surgery should be mentioned. So you have to ask in detail about the delivery, the difficult labor, the instrumental delivery, the surgery, the history of malignancies, prior radiotherapy, whatever the risk factor of the fistula, you have to ask in detail for the diagnosis. The woman also has the pruritus vulva, the rash. The many patients with obstetric fistula are amenorrheic. That reflects the gross tissue loss within the pelvis or hypothalamic influences resulting from physical and emotional effects of a traumatic labor, stillbirth, and the fistula development. What are the signs? What are the examination findings? You suspect the fistula. On the vulvar inspection, there is escape of ammonia, smelly, watery discharge per vagina is characteristics. Urinary smell, evidence of reddening and excoriation of the vulval scans, varying degree of perineal tears may be present. If the fistula is big enough, its position, size, and tissue at the margins are to be noted. There may be a varying degree of vaginal atresia so as to make the fistula inaccessible. On the speculum examination, a Sims speculum in Sims position gives a good view of anterior vaginal wall when the vagina becomes ballooned up by air because of negative suction. Note the size, site, and number of the fistula. Often the bladder mucosa may be visibly prolapsed through the big fistula. A tiny fistula is evidenced by a puckered area of vaginal mucosa. Associated clinical features that may be present in cases of such fistula including the secondary amenorrhea, menstruation resumes following successful repairs, foot drop due to prolonged compression of the sacral nerve root by fetal head during labor, complete perineal tears, or rectovaginal fistulas. How we confirm that this is the fistula? The confirmation of the diagnosis is most often made from a typical history and local examination, but sometimes confusion arises in a case of tiny fistula for which additional methods are to be employed. The confused clinical conditions mean differentials or the stress incontinence, uretrovaginal and urethrovaginal fistula. To confirm the diagnosis, following tests are helpful. The examination under anesthesia is needed for a better evaluation and essential preliminary to definitive surgical treatment. Vaginal assist can be assessed at the same time to decide for the route of repair. What we do, patient is placed in a Sims or niches position, and while examine the anterior vaginal wall, the bubbles of air are seen through the small tiny fistula when the woman coughs. A metal catheter passes through the external urethral meatus into the bladder. When it comes out through the fistula, not only confirms the VVF but ensures the patency of the urethra. Dye test remains the investigation of first choice. A speculum is introduced and anterior vaginal wall is soft dry. When the methylene blue solution is introduced into the bladder by a catheter, the dye will be seen coming out through the opening. See here. The traditional three-swab test gives a less clear distinction between urethral, extraurethral leakage and precludes the identification of multiple fistulas. So it's not therefore recommended. If leakage of clear fluid continue after installation of a dye, a ureteric fistula is likely. This is most easily confirmed by a two-dye test using phenazopyridine to stain the renal urine and methylene blue to stain the bladder contents. So what we do, we introduce the three swabs into the vagina, upper vagina, middle vagina and lower vagina. Introduce a dye, the methylene blue. If the lower vagina is stained, this is urethral, it's a bladder. If no staining and the clear, this is the ureter, leakage, the clear fluid. And if we give the phenazopyridine intravenously, it will stain the urine from the kidney and this will stain. So this is called a double dye test, two dye test or double dye test. So observation, these are the same observations. Urethrovaginal, vesicovaginal and uretrovaginal. This is the interpretation of this picture. How we prevent the obstetrical fistula? The obstetrical fistula in the developing world can be prevented with safe motherhood initiative. Women with obstetric vesicovaginal fistula is considered as a near miss. Gynecological fistula can be prevented with better anticipation and improved surgical skills. Guidelines for the prevention includes the adequate antenatal care is to be extended to screen out at-risk mothers likely to develop the obstetric labor. Anticipation, early detection, and ideal approach in the method of delivery in relieving the obstruction. Continuous bladder drainage for a variable period of about 5 to 7 days following delivery, either vaginally or abdominally in case of obstetric labor. Care to be taken to avoid injury to the bladder during pelvic surgery, obstetrical or gynecological surgery. Once you diagnose, then how you manage the fistula. The management of the most genitourinary fistula needs a team approach, both by the consultant gynecologist, nursing staff, and the urologist. These socially restricted women need realistic counseling. Otherwise, the treatment failure may cause further devastation. Once the diagnosis is made, continued catheterization for 4 to 8 weeks is maintained. This may help spontaneous closure of small fistula, size is 2 mm to 2 cm diameter. Fistula straight in about 50 to 60% of the cases. So small size fistula straight, spontaneous closure by continued catheterization in 50 to 60% of the cases successful. Unobstructed outflow tract help epithelialization provided the tissue damage is minimum. Palliation and skin care. Incontinence pads should be provided in generous quantities for the interval between diagnosis and repair. जब तक repair हो incontinence pads use करें ताकि urine ammonia उसको रेश नहीं कर दे. The vulval skin may be at considerable risk from ammonical dermatitis and liberal use of silicone barrier cream should be encouraged. Principle of the surgery. What are the principle of the surgery? If the examiner is asking from you, okay, what is immediate management? Immediate management क्या है? Consultants को बताना है ना? Consultant team को बताना है, patient को बताना है. और diagnosis हो गया है या तो continuous catheterization करेंगे, skin की palliation care करेंगे. Principles of the surgery. The best chance of cure is at first operation. To avoid repeated failures of repair, skilled urological surgical team should be involved. A correct pre-operative assessment and preparation. Timely repair. Repair should be tension-free. Presence of healthy vascular tissue at the fistulous margin. Perfect asepsis and good exposure of the fistula. excision, minimum of the scar tissue around the margins, mobilization of the bladder wall from the vagina, suture the bladder wall without tension in 2 layers, post-operative bladder drainage, no kinking, no blockage of the catheter. So these are the principles of the surgery. If the examiner is asking from you what are the principles, you have to tell them in detail. Pre-operative assessment. Fistula status assess करना है. Assessment is done as records the site, size, number, mobility and extent of fibrosis at the margin of the fistula. अब assessment करनी है किस साइड पे है, सब सिम्फेजल है, जक्सा सर्वाइकल है, मिड वजाइनल है, साइज क्या है उसकी, नंबर कितने हैं, मोबाइल है एरिया, सराउंडिंग एरिया, फाइब्रोसिस कितना है, वजाना की लेंथ कितनी है. Urethral involvement is assessed by introducing a metal catheter through external urethral meatus into the bladder. To ascertain the position of the ureteric openings in relation to the big fistula, cystoscopy is indicated. जब आपको पता है कि यहाँ पे बिग फिस्टुला है और आपने यूरेट्रिक ओपनिंग्स को देखना है कि प्री ऑपरेटिवली वी इंट्रोड्यूस द यूरेट्रिक कैथेटर, यू नीड द सिस्टोस्कोपी. To exclude associated rectovaginal fistula are complete perineal tears, complete hemogram and urea. This also exclude rectovaginal fistula or complete perineal tears. अगर ये भी हैं तो आपको ये भी रिपेयर करने पड़ेंगे. Complete hemogram and urea creatinine in renal function estimation are done. The pre-operative investigation must be done. CBC है, urea है, creatinine है, viral marker है, renal function है, ये सारी चीज़ें आपने करवानी है before the surgery. और अगर बड़ी उम्र की है तो फिर उसका कार्डियक स्टेटस भी देखना है. तो यंग है तो नो इशू, एंड इफ द मोर देन 40 यू हैव टू डू द कार्डियक स्टेटस. द प्री ऑपरेटिव प्रिपरेशंस, द इम्प्रूवमेंट ऑफ जनरल कंडीशन इज एसेंशियल प्रायर टू सर्जरी. Most of the patients with obstetrics are usually from poor socioeconomic status and socially ostracized. Local infection in vulva should be treated by application of silicone barrier cream cyclosporine. Urinary tract infection agar hai should be corrected beforehand. It's preferable to collect the urine for the rule out of the urinary tract infection. The urine collection from the indwelling catheter keep following the surgical repair. The preoperative collection is best to be done through ureteric catheterization. Urine collected through vaginal speculum will not serve the purpose because of the contamination. It is advised to start urinary antiseptic at least 3 to 5 days prior to surgery. यूरिनरी कैथेटर पास करना है, इंडिविलिंग कैथेटर, ताकि यूरिन बैग में कलेक्ट हो. जितना भी हो रहा है पोस्ट ऑपरेटिव रिपेयर, प्री ऑपरेटिव कलेक्शन इज बेस्ट टू बी डन थ्रू यूरेटिक कैथेटराइजेशन. Informed consent. Discussion should include the potential risk. These include but are not limited to the following. These include but not limited. कुछ भी हो सकता है. So ureteral injuries, the bladder injuries, the bowel injuries, the recurrence of the fistula, the persistent fistula, sexual dysfunction, de novo urinary dysfunction, bleeding, infection. So inform the patient regarding all these issues post-operatively or intraoperatively. You must inform the patient if Mauritius faith pad or graceless muscle flap will be used. Definitive surgery is the local repair by flap splitting method is the preferred surgery. The time of repair, the ideal time of surgery is usually after 3 months following delivery. By this time, the general condition improves and local tissues are likely to be free from infections. हम ये इतना टाइम क्यों दे रहे? By this time, the general condition improves and local tissues are likely to be free from infections. Further delay is likely to produce more fibrosis and unnecessarily prolong the misery of the patient. Surgical repair of uncomplicated fistula may be done early without routine waiting for 3 months. Ureteral stents may be placed when needed. Surgical fistula, if recognized within 24 hours, immediate repair may be done provided it is small. Otherwise, it should be repaired after 10 to 12 weeks. The radiational fistula should be repaired after 12 months. Route of repair, it mostly depends upon the assist to the fistula site and the tissue mobility of the vagina. Either the abdominal or vaginal route may be approached according to the choice and expertise of the surgeon. Advantages of vaginal root repair are less blood loss, less morbidity, short hospital stay. Which suture material is used? Polyglactin, Vacryl number 20 suture material is preferred for both the bladder and the vagina. PDS 0 on a 13 round body needle 40, PDS 40 on a 13 round body needle is used for the ureter. 30 PDS on a 30 round body needle is used for bowel surgery. So if the examiner is asking about the suture material for the bladder, 20 Vacryl, for vagina for the bladder, for ureter, PDS polydixinone 40, 30 PDS on 30 round body needle is for bowel surgery. Steps कैसे रिपेयर करना है? So vaginal mucosa is dissected off the bladder wall around the fistula site. The fistula tract is excised. क्या करना है? फिस्टुला है उसको circumscribed incision दे दे. vaginal mucosa को separate करें from the fistulous tract. Fistulous tract को excise करें, fibrous tissue को निकाल दें. Then start the repair in 2 layers. The first layer is with polygalactin, the Vacryl 20 suture, 30 needle is preferred. Interrupted stitch लगाने, 3 space, excluding the bladder mucosa are done. अब क्यों bladder mucosa को exclude कर रहे हैं? Why not include? Because to prevent the stone formation, अगर stitch अंदर ही होंगे तो stone भी बनेगा और अगर ureter edge पे है तो वो भी बच जाएगा. नहीं तो it will cut the ureter in the stitch line. The second layer is with interrupted sutures again, using the same suture material, taking the muscle and facial layer of the bladder wall, burying the first suture line. जैसे सिजेरियन में हम फर्स्ट लेयर को बरीड करते हैं, the second layer से सेम यहाँ भी बरीड करना है. इंटरप्टेड सुचर लगेंगे फर्स्ट लेयर में भी, सेकेंड लेयर में भी. अपोजिशन ऑफ द वजाइनल वॉल बाय इंटरप्टेड सुचर. अब आगे वजाइना पे. ये तो हो गया था ब्लेडर, फर्स्ट लेयर 2 लेयर. नाउ वजाइनल वॉल इंटरप्टेड सुचर वहाँ भी लगेंगे. सुचर मटीरियल 0. क्लोयर मस्ट बी वाटर टाइट एंड इज टेस्टेड बाय डाई इंस्टॉलेशन इनटू द ब्लेडर एट द एंड ऑफ द ऑपरेशन. आपने ऑपरेशन ख़त्म कर लिया, यूरिथ्रल कैथेटर से आपने डाई डाला और देखा कि टाइट क्लोयर है, वाटर टाइट सील है, ताकि अगर लीकेज है तो वहीं पे ही रिपेयर कर ले. सो ये वजाना क्लोज करने से पहले चेक करते हैं. व्हेन फर्स्ट लेयर, सेकेंड लेयर, फिर चेक करते हैं, फिर वजाना को क्लोज करेंगे. To maintain the continuous bladder drainage by an indwellant catheter is maintained for 10 to 14 days. अब 10 दिन से 14 डेज तक कैथेटर रखना है, कंटिन्यूस ब्लेडर ड्रेनेज करनी है, किंकिंग और ऑब्स्ट्रक्शन को अवॉइड करना है by good nursing care. The catheter must be of sufficient diameter to prevent the blockage, but whether the suprapubic or urethral route is used is continuous. It is the author practice to use both urethral and suprapubic catheter as a belt and brace approach. This also allows the suprapubic catheter to be used once the patient is voiding to assess the residual volume. The duration of the free drainage depends on the type of the fistula repaired. Following repair of surgical urogenital fistula, 12 days should be adequate. Some advocate routine cystography to check the integrity of repair prior to catheter removal. This is not the author practice if surgery and post-operative course has been straightforward. If ureteric openings close to the margin, introduce ureteric catheter prior to repair to prevent the inclusion of ureteric opening in the sutures. This is very important. Involvement of the bladder, neck, suprapubic or vaginal cystostomy prior, and as temporary urinary diversion to keep the repair area free from the getting wet. Associated with the current procedural terminology, CPT or rectovaginal fistula, RVF. To repair the VVF first, followed by repair of the CBT or RVF in same sitting. Sensorization, pairing and sutures. Repair the fistula in Sims position, exposing the fistula with Sims speculum, and after pairing the margins, sutures the fistula with silver wire. Sensorization is a closure of small fistula using interrupted stitch without dissection of the bladder from the vagina. This may be employed in a very small fistula using Becquerel 20. Use of graft or interpositional flaps. Repair of big fistula may need interposition of tissue grafts to fill space and with new blood supply. Different tissues may be used: Mauritius grafts, bulbocavernous muscles, and labial fluid. Pedicles graft is used for big bladder neck fistula. Other tissue used are gracilis muscles, omental pedicle grafts, or peritoneal flap. Laparoscopic repair of genitourinary fistula currently being done in selected cases. Let's go technique is used to repair a VVF that developed following total hysterectomy operation. The principle of this operation is to produce the partial colpochlesis, the obliteration of the vagina around the fistula. This procedure is suitable for a fistula which is small and higher in the vagina. This is the let's go technique. So you must know the sensorization, the let's go technique, the use of the grafts, what are the tissue which are used in the grafts, and the laparoscopic repair. पोस्ट ऑपरेटिव ईयर, अब तो फिस्टुला हो गया, फिस्टुला डेवलप हो गया, उसको डायग्नोज कर लिया, उसको ट्रीट भी कर लिया, अब ऑपरेशन हो गया, अब क्या करना है? पोस्ट ऑपरेटिवली IV fluids, analgesics, urinary antiseptics, either given at random or appropriate to the culture and sensitivity report. Continuous bladder drainage for 10 to 14 days. Nursing staff should check catheter early throughout the post-operative period to confirm free drainage. ऐसे नहीं है कि आपने सर्जरी कर दी और छोड़ दो, पता चला कि कैथेटर किंकिंग हो गया था, ब्लॉक हो गया था और उसने स्टिच लाइन को वीक कर दिया और वहीं से लीकेज शुरू हो गई. नो, एवरी और नर्सिंग स्टाफ शुड चेक द कैथेटर. Regarding the mobility, restricting patient mobility in the post-operative period may help prevent kinking of the urinary catheters, which can obstruct free drainage and endangers the repair. Moderate risk of VTE due to restricted mobility, so VTE prophylaxis like low dose subcutaneous heparin until the patient is fully mobilized, and even the TAD stockings. The patient is advised to pass urine frequently, every 1 hour. Once the catheter is removed, the 1 hour patient pass the urine. The interval is gradually increased. Advised during discharge to pass the urine more frequently. What care she is taking at home to pass urine more frequently, to avoid intercourse for at least 3 months, to defer the pregnancy for at least 1 year. If conception occur, report to the hospital and must have mandatory antenatal checkup and hospital delivery. Successful repair should have an abdominal delivery. If the repair fails, local repair should again be attempted after 3 months. Fistula may become smaller when the second attempt may be successful. This is a criteria for successful repair. Criteria: good prognosis, uncertain prognosis. Fistula छोटा है, vesicovaginal है, less than 4 cm है, urethral involvement absent है, vaginal scarring absent है, tissue loss minimum है, urethral involvement नहीं है, circumferential defects absent है. So these have the good prognosis. The fistula which are multiple, involving the mixed fistulas, VVF, RVF, more than 4 cm साइज का है, यूरिथ्रा भी इन्वॉल्व है, वजाइनल स्कारिंग भी प्रेजेंट है, बहुत सारे टिश्यू लॉस हो गए हैं, एक्सटेंसिव टिश्यू लॉस है, यूरिटर्स भी इन्वॉल्व है, वो भी वजाइना में लीक कर रहे हैं, सर्कमफ्रेंशियल लॉस भी प्रेजेंट है. दीज आर विद अनसर्टेन प्रोग्नोसिस. प्रिंसिपल्स इन द मैनेजमेंट ऑफ गायनोकोलॉजिकल VVF. अब जो ड्यूरिंग सर्जरी हो रही, डिटेक्टेड ड्यूरिंग द ऑपरेशन, अगर वो ऑपरेशन के दौरान आपको पता चल गया है, to repair immediately in 2 layers. अगर पोस्ट ऑपरेटिव पता चला है, to put in catheter for 10 to 14 days. If it fails, repair done after 3 months. Malignant or post radiation, any of the following may relieve the symptoms. अगर malignant fistula है या रेडिएशन के बाद हुआ है तो इनमें से कुछ भी बेनिफिशियल है. इलियल ब्लेडर, इलियल कंड्यूट, anterior excentation, be done first following by local repair. Follow up कब करवाना है? 2 to 3 weeks for post-operative imaging. After 2 to 3 weeks, retrograde pyelography करवानी है. 6 to 12 weeks for clinical examination. Post-operative complications, early and late, excessive bleeding, surgical wound infection, urinary tract infection, continuous urine leakage through fistula, the late risk of abdominal and pelvic adhesion if repair is done abdominally, risk of dyspareunia and tenderness if vaginal approach is used, reduced vaginal length, shortening and stenosis if vaginal approach is used. Now coming to the case. केस सिनेरियो है, तो आपने सारा फिस्टुला पढ़ लिया कि फिस्टुला क्या चीज़ है, उसके टाइप्स क्या हैं, ये कैसे होता है और डायग्नोस कैसे करना है, उसका कॉम्प्लिकेशंस क्या हैं, रिपेयर कैसे करना है, कौन से तरीके हैं रिपेयर करने के. तो नाउ कमिंग टू द केस, आपने ये सब कुछ पढ़ लिया है. देखते हैं कि आप ये सॉल्व कर सकते हैं या नहीं कर सकते. 50-year-old woman who underwent vaginal hysterectomy, abdominal hysterectomy और abdominal hysterectomy, vaginal हुई है या abdominal हुई है. 20 days ago, she now came with complaining of watery vaginal discharge. क्योंकि कभी कभी एग्जाम में आता है कि vaginal hysterectomy हुई है, कभी कभी आता है कि abdominal hysterectomy हुई है. ठीक है, कभी कभी आता है कि इसको फॉर्सेप लगे, कभी कभी आता है कि इसको कुछ नहीं हुआ है. तो इन द केस वेयर वजाइनल कभी कभी होता है कि इसको फॉर्सेप लगे, कभी कभी होता है कि ऑब्स्ट्रक्टेड लेबर था, डिफिकल्ट लेबर था. सो वजाइनल हिस्टेक्टोमी या एब्डोमिनल हिस्टेक्टोमी के बाद पेशेंट को कंप्लेनिंग ऑफ वाटरी वजाइनल डिस्चार्ज, ये एक सिनेरियो है. सो क्वेश्चन इज व्हाट डायग्नोसिस डू यू सस्पेक्ट. आपके माइंड में क्या आएगा? एक मरीज़ की हिस्टेक्टोमी हुई है 20 दिन पहले, अभी उसको वाटरी वजाइनल डिस्चार्ज हो रही है. आपके माइंड में आएगा क्या कि क्या चीज़ है उसको? यू कीप इन योर माइंड द डिफरेंशियल्स. मे भी हो सकता है यूटीआई हो, यूटीआई की वजह से ओवरफ्लो इनकंटीनेंस हो उसको, या उसका पेशाब बह जाता हो, कंट्रोल ना हो उसको, पाल्विक हेमेटोमास हो, एब्सिसिस हो, वुंड इन्फेक्शन हो गया है या फिस्टुला बन गया है. ये चीज़ें आएंगी ना माइंड में कि या तो यूटीआई हो गया या पेल्विक हेमेटोमा है या पेल्विक एब्सिस है या वुंड इन्फेक्शन है या ओवरफ्लो इनकॉन्टिनेंस है या फिस्टुला बन गया है. तो हमें कैसे कंफर्म करना है? नेक्स्ट स्टेप क्या है टू कंफर्म और रिफ्यूट द डायग्नोसिस, या हाउ यू एवेल्युएट टू रीचेक द डायग्नोसिस बाय टेकिंग द हिस्ट्री. अब हिस्ट्री में क्या है? ऑनसेट कि कब से है, रिलेशन टू हर ऑपरेशन, ये कब से है, जब से ऑपरेशन हुआ है तब से. एनी स्मेल, अर्जेंसी, फ्रीक्वेंसी, डिसयूरिया, अगर ये है दैट इंडिकेट द यूटिया. इफ देयर इज कंटिन्यूस लीक हो रहे, सेंस सर्जरी है, वीवीएफ, ओवरफ्लो इनकॉन्टिनेंस और pelvic abscess, whether she is able to void or not. अगर वाइट नहीं कर रही, उसको फील नहीं हो रहा, वो कंटिन्यूस बह रहा है, इट्स vesicovaginal fistula. यूरिनरी प्रॉब्लम प्रायर टू ऑपरेशन, उसे पूछना है, को पहले तो कोई मसला नहीं था, पहले पेशाब बह तो नहीं जाता था खांसी से या इससे कोई मसला तो नहीं था. दैट मे इंडिकेट द ओवरफ्लो इनकॉन्टिनेंस. आस्क फॉर द फीवर, बुखार तो नहीं है, पेट में दर्द तो नहीं है, पेट में कोई गोला सा तो महसूस नहीं हो रहा, दर्द तो नहीं है वजाइना में. ये चीज़ें यू हैव टू आस्क रिगार्डिंग द एब्डोमिनल पेन, रिगार्डिंग स्वेलिंग्स. सो कीप इन माइंड कि आप क्यों पूछ रहे हैं. मैं एब्डोमिनल पेन का पूछ रही हूँ, स्वेलिंग का पूछ रही हूँ, हो सकता है हेमेटोमा हो, एब्सिस हो, बुखार हो सकता है यूटीआई है, पेल्विक एब्सिस बन गई है, वुंड इन्फेक्शन बन गया है, पेन इन वजाइना मे बी ड्यू टू द वुंड इन्फेक्शन. तो मुझे ऑपरेटिव नोट्स भी देखना पड़ेंगे. आई वांट टू सी योर ऑपरेटिव नोट्स फॉर एनी कॉम्प्लिकेशन एंड रिकवरी. उसके बाद आपने डिटेल में हिस्ट्री लेनी है, उसकी पास मेडिकल हिस्ट्री, वो डायबिटिक तो नहीं है, कोई दवाई तो नहीं ले रही है, पास सर्जिकल हिस्ट्री, फैमिली हिस्ट्री, ऑब्स्टेट्रिकल हिस्ट्री के डिफिकल्ट लेबर तो नहीं था, प्रोलॉन्ग लेबर तो नहीं था, इंस्ट्रूमेंट्स तो नहीं लगे उसको, menstrual हिस्ट्री, contraception, pap smear, medication, allergy, addiction and socioeconomic status. This is routine history. Apart from this, how you diagnose, evaluation to recheck the diagnosis. एग्जामिनेशन, हिस्ट्री के बाद मैं एग्जामिनेशन करूंगी. उसमें क्या क्या देखना है मुझे? ब्लड प्रेशर, पल्स, टेम्परेचर, रेस्पिरेटरी रेट. जनरल फिजिकल एग्जामिनेशन फुल देखना है, बीएमआई देखनी है, थायराइड, ब्रेस्ट, चेस्ट एंड हार्ट एग्जामिनेशन फॉर द फिटनेस ऑफ सर्जरी. क्योंकि मुझे तो इसकी सर्जरी करनी है. अगर मैंने इसको डायग्नोज कर लिया है तो मैं सारा इसका मुआयना करूंगी. इसकी सर्जरी हुई है, हो सकता है इसको इन्फेक्शन हो, इन्फेक्शन की वजह से इसके वाइटल्स डीरेंज हो. Abdominal infections for local tenderness to rule out abscess, hematoma, previous scars, perineal examination or vulvar inspection. Inspect the discharge on the plate. Color, their smell. Watery vaginal discharge with urinary smell, excoriation of skin, varying degree of perineal tears may be present in the BVF. Digital vaginal examination for pelvic collections. Speculum examination in SIMS speculum to inspect for urine leak and inspect the vaginal wall wound infection. Look for fistula. Big fistula easily seen in the anterior vaginal wall. Its position, size, and tissue at the margins are to be noted. The bladder mucosa may be visible prolapse through a big fistula. At times, there may be a varying degree of vaginal atresia so as to make the fistula inaccessible. अगर atresia है तो आपको fistula का पता नहीं चलेगा. If small fistula, tiny fistula is evidenced by a puckered area of vaginal mucosa and ask the patient to cough, then air bubble seen. The next question, the investigations, the full blood count, looking for total WBC count that will indicate the infection, blood group, RBS, viral marker, urea creatinine and electrolyte to establish the baseline renal function, urine detailed report, the catheter specimen of the urine, midstream urine for culture and sensitivity to exclude the UDA, culture and sensitivity of the discharge, dye test, that's a methylene blue 3 soft test, 2 soft test. CT urogram is a gold standard in the UK for diagnosis of the fistula. Retrograde pylography for the diagnosis of exact site of ureterovaginal fistula. Endoscopic study or cystourethropy for all but the largest defect. This allows the determination of the exact level of position of the fistula with relation to the ureteric orifice and the bladder neck. Malignant changes have been reported in long-standing benign fistula. Thus, if there is any doubt about the nature of the tissue, biopsy should be undertaken. Now, the patient diagnosed हो गया, उसको VVF है. अब क्या करोगी? VVF डायग्नोस हो गया है तो मैं अपने कंसल्टेंट्स को इन्फॉर्म करूँगी, मैं यूरोलॉजिस्ट को इन्फॉर्म करूँगी और मैं पेशेंट को भी इन्फॉर्म करूँगी. क्या पेशेंट से बोलना है? पेशेंट नीड टू बी इन्फॉर्म्ड इफ देयर इज अ ड्यूटी ऑफ कंडोर. Apologize to the patient. Tell her this is uncommon complication of the surgery but recognized. Explain her why it is occurred and that care will be taken over by multidisciplinary team. Gynecologists that include the gynecologist, urologist, anesthetist, nurse, physiotherapist. Why vesicovaginal occur? उसको ये भी बताना है अपने मरीज को कि ये क्यों हुआ है in her own language. The bladder is close to the vagina. उसको ये बताना है कि bladder is close to the vagina anatomically and misplaced sutures may have incorporated to the bladder into vagina or due to avascular necrosis as a result of infection or hematoma. या तो सुचर लग गया ब्लेडर में जिसकी वजह से इस्कीमिया हुई और यूरिन बहना शुरू हो गया, या फिर टिश्यू नेक्रोसिस हुआ है फ्रॉम इन्फेक्शन और हेमेटोमा. Because the bladder and vagina are close. Fill an incident form and notify the risk management team. अपने ये सब कुछ कर लिया, उसके बाद क्या करना है? मरीज को बैरियर क्रीम्स प्रिवेंट द स्किन एक्सकोरेशन, incontinent beds, antibiotics. Further management will depend upon the urologist review. अब आपने urologist को बताया था, वो भी आ गया है. Either long term catheterization for 3 months or surgical repair which can be abdominal or vaginal. ये urologist डिसाइड करेगा कि इसको हम कैथेटराइज करें या इसकी सर्जरी कर दें. Follow up regularly and shared care. Clinical governance, 5Ds, documentation, debriefing, DVT risk assessment, tactics. Tactics is the clinical risk assessment. 5th D is discharge, 24 hours, phone number, follow-up advice. Discharge, 24 hours phone number, follow-up advice. Sometimes the other viva questions, the gishri, they may ask what is the gishri. This is a traditional cut made into the vaginal introitus with a razor blade or knife to treat the numerous gynecological conditions. Phenazopyridine dye is oral formulation of an orange dye which is excreted in the urine. It has traditionally been used to stain the urine and hence confirm the presence of the fistula. Unfortunately, it has become increasingly difficult to obtain in the UK. Indigo caramine may be used IV as an alternative. सो फेनिजोपायरिडीन नहीं मिल रहा है ओरल तो IV इंडिगोफेरेमिन दे दें। थैंक यू।